Good evening, everybody, and you're all welcome to the second session of Venous Association of India. It's a live in box training program with some difficult topics which we are not able to discuss in the routine conferences more than 8 minutes. But here we can go into detail, and we are going to be talking to the experts in the field, and we are trying to involve people from who are doing some work in this field. So I'm very happy today thank Serdia Pharmaceuticals for sponsoring this event of ours. If we look into Serdia Pharmaceuticals, all the products, they are not made in China. They all are sourced from France. It's a very thing which Serdia really wants to put it to all the speakers and people who are into the meeting. And this is a very important thing. Serdia Pharmaceuticals, along with Venous Association of India, they have put in this Facebook page called We Move. And what we are doing is we are trying to create a venous awareness. Screen again. Okay, so we are on the again. So telling about this, I think this is a very important thing. There are 4 talks already on this page. Around 38,000 people have attended this page, and we are very happy. I think this will go a very long way. And in the next 3 to 5 years, we are going to add around more than 100 videos and training programs on this, and awareness talks for the public. So please, all of you, I request, please go to this page and like it. And this will be very useful to everyone. Coming soon, 17th of July, will be Dr. H.S. Bedi's, and Dr. Shopadaria's talk has been added just now, in the last 2 or 3 days. And Dr. H.S. Bedi's talk is going to be updated soon on 17th of July. So please don't miss it. The talk is What are varicose veins? And Serdia Pharmaceuticals wants to thank everybody to include their contribution in the programs. This was the talk last time, on venous malformation. You can get their recordings on the YouTube if somebody has missed the talks. Now, this is the guidelines. I just wanted to go through it, the people who have joined this time. I'm just going to introduce the speakers, all the chairpersons and the panelists. Then I'm going to hand over the mic to the chairpersons, and the chairpersons can then invite the speaker, Dr. Shoaib Padaria, today. He's going to deliver his talk for 20 minutes. Then the chairpersons can introduce the next speaker, the case presentation by Dr. Preeti Jindal this time, and that will be for 7 to 8 minutes. And then we are going to take all the questions at the end. So before everybody starts asking the questions, what we're going to do is the chairperson is going to ask the questions to the speakers, both the speakers, and then they are going to invite the panelists, both the panelists, to ask the questions to the speakers. And then we are going to open our Pandora of questions, whatever you want to ask. It's very difficult that we unmute all the questions. So please, I will request, please put in all your questions in the chat box. Then the chairperson can take each and every question from the chat box, because there are sometimes the questions are duplicate, and so the chairpersons can decide what all questions to be taken up from the chat box to the speakers and panelists, and then we will try to wind up the program at the end of 1 hour. So today's you can see the speaker is Dr. Shoaib Padaria. He doesn't need any introduction. He's past president of VAI, a very famous cardiologist and metabolic from Mumbai, and he's going to talk about DVT in pregnancy. His interest is there in this subject, so that's why he's giving in the talk, and he has delivered this talk many times across the country. The case presentation will be Dr. Preeti Jindal. She is an obs gynecologist, and she is the president of Mohali Obs and Gynae Society, and she's going to do a presentation on DVT pregnancy, her experience. We have chairperson Dr. Rajiv Parekh, and he's the head of the department of vascular surgery at Medanta, Delhi. And I'm sure he must have joined by now. He was on the midst of traveling from office to home, so I hope he joins up. Dr. Imad Hussain, he's the chairperson from Egypt. He's a vascular surgeon and he heads the department of vascular surgery over there. Dr. Navneeta Patnaik, she is an associate professor of Ops and Gynae in All India Institute of Medical Sciences at BD Naga and Telangana. And Dr. Shantanu Ghosh is a vascular surgeon at Bangladesh, Dhaka. So thank you everybody. And last slide with saying this, just a minute. That please don't miss the third session next Wednesday. A very important session for everybody, live training on laser ablation of varicose veins, whatever we can do online. So we got eminent speakers and case presentations and the panelists. Please do join us for that. So now I hand over the mic to the chairpersons, Dr. Rajiv Parikh and Dr. Umaid Hussain, if they are here on the panel. Vishal, did you got in touch with Dr. Parikh?
Yes, sir. I mailed to Dr. Imad. I think he will be joining soon. And Dr. Rajiv is not joined, sir.
Okay, fine. What we can do is I'll chair the session up to that time, up to the time the people joined up. I'd like to introduce Dr. Shoaib Padaria again. And welcome, sir. And please, you can share your screen and you can start the presentation on DVT in pregnancy.
All right. Good evening, friends. First of all, thank you to Venous Association of India and Serdia Pharmaceuticals for taking care of this program. And a very warm welcome to all my co-participants in this show, Dr. Preeti Jindal, Dr. Rajiv Parikh, Dr. Imad Hussain, Dr. Patnaik, and Dr. Shantanu Ghosh. Now, you'll all agree that DVT in pregnancy and postpartum period is a very, very vast topic. And in the next 20 minutes, which are allotted to me, I'll be basically talking on the various salient features which may be of clinical and practical interest to us. All right, so we know that when DVT and pulmonary embolism, or what is called venous thromboembolism, VTE, is a global.
Are you okay, sir?
And DVT pulmonary embolism causes more people to die annually than breast cancer and AIDS combined. So it's a major problem. Now it comprises of two conditions, as we know. One is pulmonary embolism, the other one is deep vein thrombosis. When we talk of pulmonary embolism, it is responsible for about 40% of the non-fatal cases. The severity of PE depends on the size as well as the cardiopulmonary reserve of the patient. It has been found that subsegmental pulmonary embolism is an important risk factor for recurrence. And 30 to 70% of them have residual DVT. So it's not necessary that every patient of pulmonary embolism, when you do an ultrasound, you'll find an existing DVT. The clot may actually have broken up and embolized, actually missed the DVT. As far as DVT itself is concerned, it is responsible for about 60% of non-fatal cases, and proximal DVT, which is iliac and femoral DVT, is a prognostic marker for recurrence as well as mortality. Now, how about venous thromboembolism in pregnancy? We know that pregnant women have a 4 to 5 times increased risk of symptomatic venous thromboembolism. The estimated incidence is about 1 to 2 per 1,000 pregnancies. 85% of DVT are in the left lower extremity. In developed countries, pulmonary embolism is the leading cause of maternal mortality. Now, we all know why a thrombosis occurs. The physiology of Warshaw's triad says that there are 3 causes. One is the hypercoagulable state, one is the endothelial injury, and third is venous stasis. All of you know the various reasons why these 3 things occur, And as far as pregnancy is concerned, all these three factors play an important role. How about the clinical presentation of venous thromboembolism? When a patient presents with pulmonary embolism, it may present with dyspnea, palpitations, pleuritic chest pain, occasional hemoptysis in massive PE. There may be cyanosis or hypoxia in massive PE. Tachycardia is almost a constant feature. Tachypnea, hypotension, and the patient may actually be in circulatory collapse when the patient presents. They may or may not have signs of DVT. On the other hand, a patient of deep vein thrombosis, when they present, there's usually unilateral leg pain or tenderness. Swelling is noticed in an extremity. There's increased calf or thigh circumference, increased temperature of the affected leg. If the patient has pre-existing varicose veins, which is a risk factor for DVT, then you might see prominent superficial veins and occasional pitting edema. What is the role of D-dimer test in a case of suspected DVT in pregnancy? Now, in non-pregnant patients, we know that D-dimer is a rapid and inexpensive test. It's useful for excluding DVT if the result is normal. If it's normal, then you know there's no DVT. If it's high, then you must look for DVT. And there are only 4% false negative results. However, when the patient is pregnant, then elevated levels of D-dimer can be seen because of various reasons. One is physiological changes of pregnancy and also preeclampsia. And therefore, in pregnant patients, D-dimer is not a good test to diagnose DVT in pregnancy. Now, what about the clinical presentation and probability of a patient having DVT? If you have a clinical probability which is high, you feel because of the clinical signs and symptoms there's a high chance of DVT, then the patient straight away goes for a venous Doppler study. If it's negative, but you still feel clinically the patient has DVT, you must give anticoagulation and repeat ultrasound in 1 week. Why is this important? Because occasional calf DVT or distal femoral DVT may not show up in the first couple of days, and it occurs, and the venous ultrasound may be positive only later. If the venous ultrasound is positive, then of course DVT is diagnosed and you start anticoagulation therapy. If there's a low clinical evidence or chance or suspicion of DVT, then you may or may not do D-dimer. I personally do not advise you. Go straight again for a venous Doppler study to see whether the patient has DVT or not. What about diagnosis of pulmonary embolism? Again, if the clinical suspicion is high, go straight for a spiral CT. Don't bother with D-dimer tests. And spiral CT is one of the best tests to find out not only the presence or absence of DVT, of pulmonary embolism, but also the extent and whether the patient needs further management. Now, a concern arises. Can you do a CT scan, a CT pulmonary angiography in a patient who is pregnant? Or would you rather do a ventilation perfusion scan? Now, a CT pulmonary angiography has definite advantages over ventilation perfusion scan because one, it has better sensitivity and specificity, a lower radiation dose to the fetus, and can also identify other pathologies such as aortic dissection, which may be a differential diagnosis to acute PE. On the other hand, there are certain disadvantages. For example, the high radiation dose to the maternal breast, which later on may be a cause for concern. Secondly, the CT pulmonary angiography may not identify very small PE. And thirdly, the iodinated contrast material may potentially alter the fetal or neonatal thyroid function. Now, in pregnancy, when exactly does venous thromboembolism occur? As far as DVT is concerned, a meta-analysis showed that 2/3 of cases of deep vein thrombosis occur antepartum, distributed equally throughout all 3 semesters. On the other hand, as far as pulmonary embolism is concerned, 43 to 60% pregnancy-related PE occur 4 to 6 weeks postpartum. This is an important differentiation. And what is the duration of postpartum risk of thrombosis? The prothrombotic changes which are associated with pregnancy do not revert completely to normal until several weeks after delivery. And clinical data have suggested the persistence of an increased risk for up to 6 weeks postpartum. There are 3 important questions we need to address. One is, how do we identify patients who are greatest risk of VTE? Secondly, in which patients do we start prophylaxis? And thirdly, is pregnancy-related VTE preventable? So the first question, can we identify people who had greatest risk? For this, we must ask one more question. Why does venous thrombosis occur in pregnancy? And there are three reasons: the physiological process of pregnancy, inherited coagulopathy, and thirdly, certain acquired risk factors. Let's go through one of all of them one by one. What are the physiological changes in pregnancy? We know that there's increased level of procoagulant factors such as 2, 7, 8, 10, and 12, decreased serum levels of protein C, protein S, and there is already a decreased fibrinolytic state. So the blood becomes thinner because of increased plasminogen activator inhibitor 1 and inhibitor 2. Then, of course, we have the inherited coagulopathies. Of which the one to be focused on is basically factor 5 laden mutation heterozygote. The prevalence is 2.7 and the odds ratio are 9. All the others are very, very rare and you can basically not give much attention to them. Then there are acquired risk factors of coagulopathy. Most important is age greater than 35, operative delivery of cesarean section, blood group A, hypertension, postpartum bleeding, and a previous history of venous thromboembolism, either unprovoked or during previous pregnancy, and of course, oral contraceptive use. A few words about inherited coagulopathy or thrombophilia. Thrombophilia is present in up to 20 to 50% of patients of women who experience VTE during pregnancy. But in most cases, it's with an associated risk factor. And the three groups of such patients: one, pregnant women who have thrombophilia and previous venous thromboembolism; two, pregnant women with thrombophilia, no previous venous thromboembolism, but with a family history of venous thromboembolism; and thirdly, pregnant women with thrombophilia, no previous VTE, and no family history. Why is this important? Because the guidelines for treatment of such patients is different. For example, those who have previous VTE event, here you have to give partum as well as postpartum prophylaxis for 6 weeks. But on the other hand, you don't have any previous VTE with or without a family history, then a minimum of 7 days of thromboprophylaxis is usually recommended postpartum. And this duration can be extended for up to 6 weeks depending on the number of concomitant risk factors. Then there are certain specific situations in pregnancy which we must address. One is called the Antiphospholipid Syndrome lupus. Commonly called APS, it is an autoimmune disease presently mostly in young women. Those with APS make abnormal proteins called antiphospholipid autoantibodies in the blood, and this can lead to dangerous clotting in arteries and veins. Antiphospholipid antibodies are present in 15 to 20% of all cases of deep vein thrombosis which occur in people under the age of 50. And these are a major cause of recurrent miscarriages and pregnancy complication, especially when no other causes are found. Now, in these patients with antiphospholipid syndrome, those patients who have a history of venous or arterial thrombosis and a positive test for antiphospholipid antibodies, in such patients, antenatal therapeutic doses of low molecular weight heparin should be given after delivery and then switch to oral anticoagulants. Those who are already on warfarin, convert them to low molecular weight heparin before 6 weeks of pregnancy. Women who are not on anticoagulants should start LMWH as soon as possible in the first trimester, which should be continued for at least 6 weeks after delivery. On the other hand, those patients who only have antiphospholipid antibodies alone, no history of thrombosis, then only low molecular weight heparin is given for 7 days postpartum. Caesarean delivery, another risk factor. Caesarean section carries an increased risk of VTE regardless of whether it is performed in the presence or absence of labor. And prophylaxis should be provided after caesarean delivery to women with the following risk factors: history of 1 or more episodes of prior VTE, history of antepartum immobilization, significant postpartum infection, postpartum hemorrhage of greater than 1 liter, preeclampsia with growth restriction, SLE, heart disease, sickle cell disease, BMI greater than 30, fetal growth restriction, multiple pregnancies, and smokers smoking more than 10 cigarettes a day. So caesarean section by itself has a great risk factor. High body mass index and immobilization are other factors. Antepartum immobilization, defined as strict bed rest for at least 1 week, sometimes given for preeclampsia, is the strongest risk factor for both anti and postpartum VTE. The effect of immobilization is further modified, increased by increased body mass index, which has a multiplicative effect. And we all know that obesity is a well-known risk factor of VT, both in the general population and during pregnancy. How about management of women who are receiving already long-term vitamin K antagonists such as warfarin? We know that warfarin readily crosses the placenta and has been associated with congenital malformation, especially in exposure from 6 to 12 weeks with fetal and neonatal bleeding. In such women who want to become pregnant, repeat pregnancy tests should be proposed and warfarin should be replaced by full dose low molecular weight heparin when pregnancy is confirmed. Now, when we come to the actual treatment of VT in pregnancy, we have to balance the benefits and risk of anticoagulation therapy. So how do we treat a patient of VT during pregnancy? First important thing is use of unfractionated heparin. This table is very important. Loading dose of 80 units per kilogram per hour and an infusion rate of 18 units per kilogram per hour. And what is our idea? To maintain the APTT between 1.5 to 2.5. Depending on that APTT ratio, you must have a dose change and additional bolus of heparin, especially if the ratio is less, so as to maintain an adequate heparization. And therefore, this table should be actually printed and put in every place where deliveries are conducted. Now, what about role of low molecular weight heparin during pregnancy? We know that it's the preferred drug. We should avoid warfarin. As far as low molecular weight heparin is concerned, once or twice daily regimen should be used. A weight-based regimen should be used in all patients. Monitoring of anti-10A factor is not required. After a full dose of treatment of 1 month, if there are no additional risk factors, an intermediate dose regimen can be considered. At least 3 months of anticoagulation is required. And if you have had idiopathic DVT or PE, at least 6 months or longer. And in all cases of anticoagulation during pregnancy, it must include the 6 weeks postpartum period. Why is LMWH preferred over unfractionated heparin? Many reasons: better safety profile for the fetus and mother, lesser risk of bleeding, lesser risk of peripartum bleeding, significantly lower bone density, which are seen in patients receiving unfractionated heparin as compared to low molecular heparin. There is no heparin intolerance, heparin-induced thrombocytopenia is not seen, and anti-factor 10A monitoring is not required. What is the dose of low molecular heparin? We commonly use enoxaparin, so I'll talk about enoxaparin. The dose is 1 milligram per kilogram every 12 hours or 1.5 milligrams per kilogram once a day. There's something called intermediate therapy of low molecular heparin. Many experts continue with full treatment dose, while some have now started doing what is called an intermediate dose. So what is this intermediate dose? You give full dose for minimum of 1 month, and then you reduce to an intermediate dose if there is no additional risk factor. And the intermediate dose which is recommended is 1 milligram per kilogram every 24 hours. It is usually 50 to 75% of the full dose. What about other anticoagulants? Fondaparinux has been studied, but as per ACCP guidelines, the efficacy is low and should be avoided. And as far as NOACs are concerned, there is insufficient data regarding this safety in pregnant women and should be avoided. Which anticoagulant can be used in nursing women? Warfarin, yes. Unfractionated heparin, yes. And low molecular heparin, yes. All studies have shown these are safe and can be given in nursing. What about treatment of life-threatening VTE in patients? Intravenous unfractionated heparin is the preferred treatment in massive VT with cardiovascular compromise. In such cases with massive PE, there's a case for considering thrombolytic therapy, especially catheter-directed, as anticoagulant therapy by itself may not reduce the obstruction of the pulmonary circulation. However, data on thrombolytic therapy in pregnancy is limited, and you must be careful about maternal bleeding and adverse fetal effects. Removable vena cava filters are a reasonable approach in women who have a transient contraindication to anticoagulants, such as the development of a VT within 1 to 2 weeks of delivery. Such cases, removable vena cava filters can be used. How long should you give the treatment in VTE? As I said earlier, a minimum of 3 months of anticoagulation therapy for secondary VTE. If it's idiopathic VTE, at least 6 months, and again, 6 weeks of postpartum treatment is a must. Not only that, along with that, mobilization of the patient with graduated elastic stockings, class 2 should be encouraged to reduce pain and swelling, also to reduce the risk of post-thrombotic syndrome for at least 2 years if possible. Minimum 6 months, but at least 2 years after occurrence of VTE. What about management of anticoagulant therapy at the time of delivery? ACCP recommendations advise stopping anticoagulation 24 to 36 hours before elective induction of labor or cesarean section. If the patient is considered to be very high risk, then minimize the time of anticoagulation. Replace the low molecular weight heparin by intravenous unfractionated. Why is that? Because it has a shorter half-life and you can stop it immediately. If spontaneous labor does occur, careful monitoring with PTT is required, and occasional protamine sulfate may be required in case of severe bleeding. In the immediate postnatal period, low molecular heparin should be started as soon as it is safe to do so, usually within 12 hours of normal delivery. And warfarin can be started at the same time. A thromboprophylactic dose of low molecular heparin should be given by 3 hours post-operatively. If there has been epidural catheter, after removal epidural catheter, 4 hours later, you can start the dose of low molecular heparin. What about prevention of VTE in postpartum period? 7 days of low molecular heparin in all these patients. Obese women, prolonged labor, immobility, infection, hemorrhage or blood transfusion, emergency cesarean section, or elective cesarean section with more than one risk factors. I would like to conclude by talking only about two things. One is early mobilization and second is compression stockings. Early mobilization, friends, does not increase the progression of VTE. There is no need for bed rest in a stable patient on anticoagulation. Pain and swelling will improve much faster with mobilization and will also help in preventing development of post-thrombotic syndrome. As far as compression stockings are concerned, you must use class 2 compression stockings. They are not to be worn at night. Thigh length stockings for thigh swelling, below knee stockings for below knee swelling. Do not wear on the affected leg and should be minimum at least 3 months post DVT, and recommended time is at least 2 years for following DVT. Thank you very much for your attention.
Thank you, Dr. Padaria. I think Dr. Parekh is and Dr. Imad Hussain has joined. Welcome, sir. And I'll hand over the mic to Dr. Parekh and Dr. Imad Hussain, please.
Good afternoon, or should I say good evening, dears, Dr. Padaria and your kind self, Dr. Abul, and our dear distinguished Dr. Roy and Dr. Bedi and everybody. It's like 3 p.m. Right now in Cairo, and it's rather hot and humid. Anyway, the very impressive presentation by Dr. Padaria has touched base on so many issues, but for the sake of time, I wish to address a couple of short questions that might be having an impact on the audience.
Yeah, Imad, can we ask the questions at the end, please? We have got another talk because that will be easier for us.
Okay.
Please, yeah. Thank you. Thank you.
So, Rahul, can I just say a few words? Right. Okay. So, congratulations on hosting these series. I think they are definitely going to be a huge benefit to most of the people who are watching and most of the people who would want to know and be abreast with all the relevant and the new advances in a very, very controversial and a very important topic. Even though we know that venous thromboembolism complicates 1.2 of every 1,000 deliveries, despite this low risk, it is a leading cause of maternal morbidity and mortality. So I think it is extremely important, and I think the clinicians, especially the obstetricians, they really need to be aware that such a disease does occur. And I think the the entire subject has been dealt very, very beautifully and masterly oration by Shoaib. So congratulations on that, Shoaib. I'm sorry I joined just a tad bit late, but I did manage to hear most of this. So of course, a lot of this we practice, and a lot of this has been refreshed by all that you have said. And I think these recommendations, either from the American Society of Hematology or from the American College of Test Physicians, will go a long way in alleviating this, and recommending treatment for this rather difficult question, situation. So I think without much more talk, I think we can go ahead and request, I think, the next presentation to go ahead. Thank you, Rahul.
Yeah, thank you. Dr. Preeti, if you can share your screen, please.
Okay.
Okay. All right. So can you see my screen and can you hear me?
Yes, ma'am.
All right. So first of all, I would like to thank Venous Association of India for giving me this opportunity, and it's nice to see so many known faces. Hello to everyone. And this is a wonderful talk by Dr. Arya. I would like to bring a very nice case. Now, deep-vein thrombosis in pregnancy is a very common thing, as we just from such a beautiful from Dr. Shoaib. Deep-vein thrombosis in pregnancy, though very recognized in India, despite everybody being telling again and again, most of the colleagues that it is a very big problem for the women and one of the main killer of women in pregnancy in the Western world. A lot of lessons have to be by the Indian gynecologist. Now, this is a very interesting case. She is 29 years old lady who went into my patient department.
You can, Vishal, you can play this slides from
Yes,
here.
sir. Yeah.
Sorry for the trouble, some problem with the internet, but then we go ahead. So again, starting the history of fifth gravida means she is carrying her fifth pregnancy at 5 weeks of gestation. And in her previous history, she had 3 miscarriages, which were at gestation of less than 10 weeks. And she has one child, which was born at 33 weeks of gestation with a cesarean section for IUGR. And in that pregnancy, that means the last pregnancy, she had thrombosis lower right leg. Now, important points to ponder in this is, yes, please, next. Michelle, can you please
Yes.
move the
Okay.
screen?
Okay.
Yeah. The important points in this case are that she has 3 miscarriages. Now, if we look 3 miscarriages alone, it's very common. Recurrent miscarriages are seen in 1% of women. That means out of 100 pregnancies, 1 woman will have 3 miscarriages. Then she had deep vein thrombosis, and as we learned from our previous speaker, deep vein thrombosis in pregnancy is also quite common. And third, she had intrauterine growth restriction in previous pregnancy, which standalone problem is around 25% of pregnancies on the newborn. But if we see all 3 of them together, then what can we conclude from it? There could be a probable diagnosis looking at our face. And next, please. So the diagnosis would be, it could be a thrombophilia. And what kind of thrombophilia? Thrombophilia, that is antiphospholipid syndrome. What is antiphospholipid syndrome? According to Royal College of Obs and Gynae guidelines, the antiphospholipid syndrome has got following criteria, that is vascular thrombosis or obstetrical morbidity along with the lab criteria. So what are the vascular thrombosis?
Ma'am, you there? Your voice is again not coming.
Is
Hello?
it coming now?
Yes, ma'am. Yes, yeah. We can hear you now.
Yes. So we can move to the next slide.
Yes. Okay.
So this is a summary of the antiphospholipid syndrome, 1 clinical and 1 lab criteria. In clinical criteria, there should be 1 vascular thrombosis and pregnancy morbidity, 1 or more deaths of normal fetus at more than 10 weeks, or 1 or more premature birth at less than 34. So if we go back to our case, our patient had a cesarean at 33 weeks because of placental insufficiency. And the third criteria is more than 3 consecutive miscarriages at less than 10 weeks, which again our patient had. So the diagnosis was straight on our face, glaring at our face, which we were just waiting to diagnose it. So her anticardiolipin antibodies were done and lupus anticoagulant was done. So lupus anticoagulant came positive. Now, something very important here is that as Dr. Kodaria said in the previous presentation that all the pregnancy is a thrombo. I will put my video off, probably that will stabilize the connection. I'm going to mute my video. I'm going to stop my video and just keep it unmuted. Right. So the lab criteria important is that there should be all these blood tests should be done out of pregnancy, because pregnancy is a thrombogenic state. So if pregnancy is a thrombogenic state, and if you do all these blood tests during the pregnancy, then the results will be skewed. So they have to be done at least 4 weeks outside the pregnancy, and the tests have to be repeated at least 12 weeks apart. This is something very, very important. Next slide, please. Now, antiphospholipid syndrome is something which has got consequences for not only for the patient, but also for the not only considering the pregnancy, but it affects the whole body. There could be cardiovascular events, dermatological events, hematological, and so on. Next, please. One thing which I would really like people to know is that if you see any pregnant patient, please do prescribe DVT stockings to these patients, as any pregnancy is a hypercoagulable state, and so DVT stockings have to be worn throughout the pregnancy as well as 6 weeks postpartum. Next, please. Next slide, please, Vishal.
Yes, ma'am.
Now, along with the acquired thrombophilia, there is a big list of inherited thrombophilia, which are also important in the obstetrical patients. Coagulation disorders can lead to thrombotic events, and they include factor V Leiden, prothrombin gene mutation, MTHFR gene mutations, protein C, PNS, and antithrombin 3 deficiencies. Screening for inherited thrombophilia is recommended in pregnant women with a history of venous thromboembolism, though its association with recurrent pregnancy loss of inherited thrombophilia is controversial. Acquired thrombophilia, that is antiphospholipid syndrome, definitely associated. So when do we investigate? They have to be investigated 4 to 6 weeks after consecutive miscarriages, and in more than 35 years of age, if a woman comes with 1 miscarriage and suffered fertility, then it probably is a good point to investigate her for some role of thrombophilias. Next, please. So in our patient, we did baseline investigations. Lupus anticoagulant was positive, and serial ultrasounds were done to keep an eye on the fetal growth. Next, please. Next slide, please. Yeah. So how do we manage her? Antiphospholipid syndrome, the first line of treatment is that we combine low-dose aspirin as soon as we would like her to, she would like to start her pregnancy. That means we do not wait the pregnancy test to be positive, and then as soon as a pregnancy test is positive, we add low molecular weight heparin injections. So normally this low molecular weight heparin injection dose is not calculated according to her weight. 40 milligrams subcutaneous per day is good enough dose if you want to prevent a miscarriage. But of course, this is a different dose than in what previous speakers spoke about. What I am right now focusing is the prevention of miscarriage in a patient with antiphospholipid syndrome. So if a patient with antiphospholipid syndrome with a history of miscarriage comes to my outpatient, then the treatment which I would start or which is recommended is low dose aspirin 75 milligram per day along with 40 milligrams subcutaneous low molecular weight heparin injections daily. And the role is there till 12 weeks. After 12 weeks, in prevention of miscarriage, rule is not very clear. But then because of thromboembolism, it has to be continued throughout the pregnancy and for 6 weeks postpartum. In absence of this treatment, only 20% of pregnancies will progress successfully. And if we start this treatment for that lady, then 80% chance is there that she would have a successful full-term outcome. Next, please. So low molecular weight heparin and aspirin and DVT stockings. Next, please. So how does the heparin act? Typically, what has been seen in these patients, the blood supply from the maternal interface to the fetal interface, it gets blocked, and typically between 6 to 8 weeks of pregnancy, there is a miscarriage. So heparin helps in preventing this by antithrombotic effect. And also, next please. Other roles of heparin are, besides antithrombotic effect, it binds to antiphospholipid antibodies, rendering them inactive. It also acts as an immunomodulator, and most important, it helps in trophoblastic invasion. So good trophoblastic invasion prevents the IUGR and abruptio complications in these patients. Next, please. I have also seen many patients who have antiphospholipid syndrome, and you start aspirin and low molecular weight heparin and still they end up in miscarriage. And here comes the role of steroid therapy, though it is still an empirical therapy. A lot of research is going on, especially for the NK cells and other immunological factors. If you would like to start the steroid therapy, then it's very important that you inform the patient that there is no evidence-based proof to support it. Next, please. Presently, this patient is 36 weeks pregnant. She has mild IUGR and we are planning her delivery at 37 completed weeks. So thank you so much. And so it is very important that we evaluate such patients, and probably her developing deep vein thrombosis in the last pregnancy at 8 weeks of gestation came as blessing in disguise, because she was put on heparin and aspirin, and probably that led to the successful outcome in her previous pregnancy. Thank you very much, and sorry for so much interruption because of the bad net. Thank you.
Thank you, Dr. Preeti, and hand over the mic to Dr. Rajiv Parikh and Professor Imad Hussain, please.
Okay, so thank you, Dr. Preeti. I think that was actually a very, very interesting case, and it is something which, which is a real life situation. That is something that you as a clinician would, of course, be facing on a day-to-day basis. But we as vascular surgeons also face fairly occasionally, but I mean fairly frequently, because of our association with the venous thromboembolism. Now, I think we can open the discussions. I think I know Dr. Imad Hussain had some questions which he wanted to ask Dr. Shoaib Padaria. So let's start off with those questions. Dr. Hussain, Dr.
Yes, sir.
Imad?
Yes, sir. I would like to ask a couple of questions to Dr. Padaria. The first one is, well, I just love to have it like in a very simple modality. Suppose I'm a patient and you are my treating doctor, and I have a history of once or twice prior VTE, and now I'm a lady and I'm pregnant. So question is, what is your strategy for me? Just secondary prophylaxis throughout the pregnancy and postpartum.
Excellent question. So this is a very practical problem which is faced by obstetricians and gynecologists when a patient comes to us with a history of previous DVT. Now here what we have to consider is two things. One is there any inherited or acquired thrombophilia component? Number one. Secondly, are there any acquired risk factors such as obesity, hypertension, hypercholesterolemia, etc.? And thirdly, has there been history of miscarriages in the past? If the patient has no evidence of any of the other risk factors, then this patient has to be protected in the postpartum period. Because the postpartum period, any person who has had a previous history of VTE, there is a very high likelihood of DVT pulmonary embolism occurring in the postpartum period up to a period of 6 weeks. Having said that, for practical purposes, most OBGYs would put the patient on some form of anticoagulation with low molecular heparin for a period of 7 days, that is 1 week postpartum. In the absence of any other risk factors, they will stop at that point. If there are other risk factors which are there postpartum, like increased blood loss during the delivery, a history of cesarean section, history of infection post-delivery, then they will continue that anticoagulation for 6 weeks. If there are significant risk factors prior to delivery, then patients would give 1 month of full dose low molecular heparin, followed by what I said earlier, intermediate dose low molecular heparin, 50% of the dose. Although these are the recommendations, for practical purposes, many patients do not agree to this. Many OBGYs also do not agree to this.
Thank you, sir.
Dr.
Quite
Padaria,
clear.
Dr. Padaria, can I just interrupt here, because
Yes.
it's very important. Just a minute. I'll just put in this slide. This slide is very important slide for this. So these are the recommended today's slide. So
Yes.
anybody with a prior VT history, look into
Yes.
this chart, if you have an unprovoked VT, so how the recommendations are: if you have provoked VT, but it's a hormonal risk factor, then what is the prophylaxis? Antepartum and postpartum is required. But if you have a provoked VT and non-hormonal risk factor, then only postpartum prophylaxis is required. So it's a very concise way. So you can.
I agree with you entirely, Rahul. This is a fantastic slide. These are the recommendations by ACCP also and the British OBGY Society also.
Yeah.
However, this basically means that for 8 months of pregnancy, you have to give some form of low molecular heparin,
Yes,
which many patients are not willing to take. And therefore, what the normal gynecologists, at least all the ones in my hospital, when I spoke to them, they said what we would like to do is look at risk factors. If the risk factors are significant, we'll tell the patients you need to take low molecular heparin. The risk factors are not significant, then we will give only in the postpartum period.
Yes, sir,
but you're right, this is the recommendation.
Because we have treated more than 15 patients in the last 2 years only with the previous DVT patients, and we have continued the low molecular heparin throughout the pregnancy.
That is the way it should be done. Correct.
Because the risk of the DVT is very high.
Yes.
And these guidelines are based on because 2% antepartum and more than 1%, postpartum recommended prophylaxis.
Correct.
Great. Professor Imad?
Yes, sir. I'm with you. Very timely slide and quite adding, of course, to the context we are discussing with Dr. Padaria. Then now comes my second and last question. Actually, a question and a sub-question, if you allow me. One of the frequently asked questions to me I've been asked this over the last probably 5 or 6 years, more than 20 times, by pregnant ladies who are being given prophylaxis antepartum and then later postpartum. When it comes for lactation period, then a frequently asked question is any drug which is being prescribed safe during lactation?
So, Dr. Imad, very practical question asked by everybody, as you rightly said. And I showed you in my slide of the presentation, all the 3 drugs, heparin, warfarin, and low molecular heparin, all 3 have been extensively studied, and they have found that their concentration in the milk is absolutely very minimal and cannot cause any harm to the child. And therefore, all 3 are safe. The only drug which has not, or group of drugs which have not been studied either during pregnancy or in the postpartum period are the NOACs. And therefore, we suggest that the NOACs should not be used either in pregnancy or in a lactating woman.
Yes. Last question, sir. I'm sorry for that again, but I cannot miss the opportunity of having you as a speaker, of course. It is directed to your kind self and probably to some other distinguished colleagues among the speakers. The tests for thrombophilia are very numerous and quite expensive in my country. So do we have to test for each and everything? I mean, of course, protein C, S, factor V Leiden, and then antiphospholipid, anti-nuclear antibodies, anti-smooth muscle cell antibodies, the lupus antibodies and everything, or we can focus just on the D-dimer, as you mentioned in your own presentation, and then look for probably factor V Leiden mutation, and that's it, with a high index of clinical suspicion, of course.
If you permit me, can I direct this question to Dr. Preeti Jindal?
Absolutely.
What would you do in your clinical practice?
Can you hear me? The question is not very good.
All right. The question is, as Dr. Imad Hussain said, that there are lots of inherited and acquired factors leading to coagulopathy. Would you investigate the patient with all these factors if you think necessary, or only a few?
Very good question. Thrombophilia screening is expensive, I think, everywhere, and in even India also it costs quite a lot. So one has to use the discretion on whom to investigate or not. As we pointed in our last two presentations, the risk factors, because usually the women coming in pregnancy or in infertility are between the age group of 20 to 45 now. Earlier it was 40, but now we see many more than 40. So if it's a history of DVT and other factors were like pointing towards antiphospholipid syndrome or thrombophilia, and in one of my slides I did mention that the age is more than 35 with a history of DVT, and she is coming, then probably we should look for the inherited thrombophilias, or if she has an obstetrical history of 3 miscarriages, less than 10 weeks of gestation, or there is a loss of 1 pregnancy in previous obstetrical history, which is before 34 weeks of gestation, with a CMF ruled out. CMF is congenital malformation. Then it probably points towards some form of thrombophilias, and then we can investigate her for acquired or familial thrombophilias. In familial thrombophilias also, instead of investigating for a full battery of tests, the one which we normally recommend to get done is the factor V Leiden, protein C, protein S, and antithrombin 3. These are the main ones. Anti-HFR gene is not that prevalent in Indian population, but then more research is required. So I feel if we use our discretion, we can save a lot of money and reach the diagnosis.
Yeah, can I just add one line to it? I'll just share one more. I've just found one more slide out of it. And, this will be quite useful. You see, all the people, all the indications, you decide, depending on Dr. what Preeti said, like it should not be done in all the patients, but anybody who has got some family histories and, where you or the patient had previous history of deep venous thrombosis where we could not be accounted for. So these are the basic recommendations which are there, which needs to be done. It's a very detailed slide, not go in detail, but factor V Leiden, protein S, protein C, antithrombin, just a minute, and homologous PGM, factor and combined. So this whole set of investigation needs to be done in all the patients. So we cannot select that because the recommendations for why the prophylaxis done or not the next pregnancy depends upon each and every test. If you can look into this, each and every test has got a different recommendation. So it's not the same, because if you have a heterozygous factor V, the recommendations are different. If you have a homozygous factor V, the recommendations are totally different. So that's why you need to, if you think that this patient will need some test, you need to do the whole spectrum. So all the 6 to 7 tests has to be done.
Thank you.
If I may make a comment here on a slightly a different aspect. Dr. Preeti, you mentioned about the use of stockings, DVT prevention stockings in patients who are pregnant. I just like to point out that when we talk of DVT stockings, the usual ones which are available in the market have a graduated pressure of only 10 to 12 millimeters of mercury, while the recommendations for stockings during pregnancy are basically that for between 20 to 23 millimeters, which is class 2 compression stockings. And so this recommendation has been very strongly advised that we must not write as DVT stockings, because those are basically 10 to 12 millimeters. What you really need are grade 2 or class 2 compression stockings in pregnancy. Rahul, correct?
That's right.
Absolutely, Dr. Padaria. Absolutely. This is very,
Correct.
yeah. Any questions from the panelists, Dr. Imad? If you can just allow the panelists to ask some questions, please.
Actually, I have a question for our speaker, Dr. Shreya. We have already discussed regarding the treatment and prophylaxis for patients who have both provoked and unprovoked DVT. But there are certain groups of, patients, without any reason, they suddenly develop DVT. So my question is, apart from treating them, what should we plan regarding their long-term anticoagulation?
As I pointed out earlier, madam, still an excellent question, because you are absolutely right. There are some cases in which you know what the underlying cause is, what is the risk factor, and we can explain those cases of DVT. But in others, we really cannot. Now, we know that the vast majority of patients of DVT in pregnancy are in the left lower limb as compared to the right lower limb. And in these patients in whom we cannot find a cause, then later on, I think we must look for something like a May-Thurner syndrome or some obstructive pathology in these patients, which, as we know, is more common in ladies, and secondly also tends to affect, for various anatomical reasons, the left lower limb. So I think a proper evaluation of these patients is important, but it may just be that because of the physiological changes of pregnancy, the DVT was provoked at that point of time. But this same DVT could probably come up even without pregnancy later on if they have some obstructive lesion there in that vein.
Okay, so that means we need to evaluate the patient, and regarding long-term anticoagulation, sir, as per that we need to decide.
True.
Okay. Actually, if you permit, I have a question for our chair, Dr. Rajiv, sir. So last time you had presented very nicely regarding the management and prevention of thrombosis in COVID patients. My question is, in COVID positive pregnant patients, how do we prevent and treat thrombosis?
I think that's a very relevant question in this day and age now, and will probably be for the next at least a year, if not more. And we will come across situations in which the COVID patients, or patients who are pregnant, not patients who are pregnant, pregnant females become patients and are suffering from COVID-19. The the essential treatment here would be the use of low molecular weight heparin. That is the recommendation. That is the recommendation in all COVID patients. And I would assume that that would be the recommendation for patients suffering from during pregnancy, patients who develops deep stage. The only directed thrombolysis or other treatments advised here, because we do not know what is the interaction and what would be the bleeding risk that would occur if any patient was subjected to catheter-directed thrombolysis. But I think the regular use of low molecular weight heparin twice a day to start off with for at least a month, and then maybe sort of go through the recommended once a day regimen would probably be in order.
Thank you, sir.
And can we ask the other panelist, Dr. Ghosh? Dr. Ghosh, are you here? Dr. Shantanu Ghosh from Bangladesh.
Yes, sir. Thank you. Thank you, Venous Association of India, for giving me the opportunity. And I want to congratulate Dr. Padaria for being elected as the Act of Phlebologic sub-editor. So I want to ask him one question. If any patient who have no previous history of DVT or any uh, uh, risk factors during pregnancy, maybe second or third trimester, suddenly develops acute DVT, would you recommend for catheter-directed thrombolysis?
I think that's an excellent question. Now, here the question is how bad that deep vein thrombosis is. If there is no basic problem to the leg, phlegma sedolens or anything major, then I would just go by regular treatment of DVT. Because the reason being that although thrombolytic therapy is very, very effective, at this point of time, the recommendation is that unless there is massive pulmonary thromboembolism, then only we should use thrombolytic therapy. And that also, if there is also, that is the only other way. There's no other reason to basically do catheterized thrombolysis, because there's harm on the patient as well as harm on the fetus. So if necessary, if the thrombus persists after delivery, then maybe you can try and recanalize that vein later on with whatever means that you want. But during pregnancy, I would not be very aggressive in view of the fact that 2 lives are involved here. No.
Yeah, Dr. Padaria, now we have got only 3 minutes left. There are a couple of questions in the chat room. I'll just go through it, please. I'll ask all the speakers and the panelists. Is there any trial or research ongoing for NOACs in pregnancy?
As I said earlier, I'm not aware of any trial, but I went through up to 3 months ago, whatever papers were published, and there is no recommendation for NOACs in pregnancy and postpartum period as of now. Yeah. Maybe and Dr. Patnaik might have some data on this.
If we can answer very please, all of you, because we got 7 questions. Yeah, please carry on.
Yeah, actually, we don't have any definite information regarding the safety of these medications in pregnancy. Yeah. So I think further trials and further studies will give us some idea.
Is, do you know of any trial which is going on for the NOACs in pregnancy?
Till now, I don't have.
Okay, fine. Let's move to the next question, please. What is the role of VKA? VKA is vitamin A, associated warfarin and acetron in Indian situation. What is the role of VKA in Indian situation? Dr. Badaria, you want to answer?
In the Indian situation, it is a little controversial, but I would say that in the long run in India, VK is not going to exist. It will all be NOACs. For the simple reason is that the INR keeps varying. Testing for the INR, PT INR is very difficult in these smaller towns and villages. And therefore, a NOACs will gradually take over. With the way the competition is coming, the prices of NOACs are dropping regularly. So in a matter of a couple of years, it will probably be as inexpensive as VK is. So the long-term future will be NOACs rather than VKs.
Yeah, I think the VK will be left over at present, for certain situations like, lactating mothers, second trimester of pregnancies, at least valve related where the NOACs cannot be used, we can still use VK. So there are certain few indications where VK are used. Renal failure, a CRF.
Renal failure would be another indication.
Yeah, that's renal failure will be another opportunities. There will be certain indications left over, but VK will be struggling to find a place. Okay, the next question is there a cause-effect relationship of pelvic congestion syndrome and DVT in pregnancy?
I'm not aware of it.
Anybody? Okay, no. Okay, Dr. Parekh, anything you want to answer?
No, I'm sorry, I didn't get the question. What was it?
Again, is there a cause-effect relationship of pelvic congestion syndrome and DVT in pregnancy?
Cause and effect. Well, I mean, with people with established pelvic vein thrombosis, pelvic congestion syndrome, they
Dr. Parekh, I think you're in the
would
car.
be at a higher risk of developing because of the congestion. That these patients would probably be treated as such. I was trying to get home to.
Yeah.
Is the reception better? Okay, so I'm just saying that pelvic vein congestion, because of the congestion, would make the patient more prone to the development of deep vein thrombosis, and would hence require prophylaxis or treatment with low molecular weight heparin. But other than that, I'm not aware of any other direct cause and effect relationship.
Fine. And sort of a last question, DVT pregnancy. So if you get massive DVT with massive pulmonary embolism in pregnancy, is that the indication for lysis and termination of pregnancy? So you want me to answer, because we have seen 2 patients out here. And if you get a massive P, so massive P, sometimes it's all depends upon, is it associated with hemodynamic disturbances or not? So if you don't have a huge right ventricular strain, if your echo is normal, and if your patient is hemodynamically stable, what that means is if your blood pressure is more than 100 and the pulse rate is less than 100, and your oxygen saturation is fine, if you are hemodynamically stable, that's not an indication for lysis. You can continue with a full dose of anticoagulation, and there is no need for termination of pregnancy. So we had 2 patients here in the last 1 year with a massive P. Both these patients actually got a full treatment dose of low molecular weight heparin. They went home and they had a delivery successfully. But if the patient is hemodynamically unstable, then you have to take the call at that point accordingly. Next question will be, can patient of history of DVT go for infertility treatment? Anybody?
Yes.
Gynecologist? Yes, please.
Yeah. I would like to answer this question. History of DVT is not a contraindication for either infertility treatment or pregnancy. The only thing is that one has to be careful that during infertility treatment, lots of progesterone and hormones are given to the patient. So if you are putting the patient on lots of hormones, you have to take all DVT prophylaxis. Otherwise, there is no contraindication.
Okay, Dr. Namrita, you want to answer? Anything you want to add on? Your mic is switched off. Yeah.
Yeah, no, as Dr. Preeti has already told, in treatment for infertility, we deal with most of the hormones, and that again presents a high risk for development of DVT. So what Madam told, that definitely we have to give prophylaxis and proceed accordingly.
Dr. Padaria, another question for you. How safe is laser varicose vein surgery in post-thrombotic leg due to pregnancy-related DVT?
No, if it's not during pregnancy, it's like any other leg. I mean, if you are doing it during pregnancy, I would strongly advise not doing any procedure, whatever it is for varicose veins. But if it's a non-pregnant patient, it's just the same as any other patient. I mean, it's safe. Yeah.
Great, wonderful. And I think we have run over time, I think because of the internet connections. I think we'll close the session. Sorry to run over time.
Thank you, everybody. Thank you.
And thank you all the speakers and the panelists and chairpersons for joining, and all the attendees to ask such an interesting questions. We will make all these presentations available on YouTube, and please don't forget to join next Wednesday for the talk. And it will be on the laser technique for varicose veins. Thank you, everybody.
Thank you, everybody.
Thank you.
Jai Hind.